Welcome to the OSG Mentoring Scheme Q&A session. This mentoring scheme is being relaunched for orthodontic specialist trainees and recently qualified specialists who are seeking a mentor for working in primary care. This scheme is free of cost and run by the BOS OSG committee. The questions we'll be asking here today are ones that frequently come up from trainees and have been compiled alongside input from the TGG. The topics we will be discussing centre around pay, both NHS and private, NHS BSA commitments, and some general questions pertaining to working in practice. We hope that this will be a valuable and informative resource for potential mentees and would advise you to watch or listen to this Q&A session first. And should you feel that your questions have not been answered here, and you feel you would benefit from a mentor, then do please get in touch. Without further delay, I'd like to invite the associate panel who will be asking questions to introduce themselves briefly.
Hi, I'm Paras. I'm a post-CCST currently, and I work in practice a couple of Saturdays a month.
I'm Arti. I work both in private and NHS practice and am a specialist working in primary care.
I'm Nadia. I'm a part-time NHS consultant and also part-time in specialist practice. And following my MWorth, I also had a break in training to spend 2 years in specialist practice before doing my post-CCST. So I've had experience in both NHS and private practice.
Hi, I'm Orla. I'm currently a post-CCST and I also had experience between my MWorth and starting my post-CCST post as an associate in NHS practice.
Thank you. I'd now like to ask the panel who will be answering the questions to kindly introduce themselves, and perhaps between you, if you could tell us what some of the pros and cons are you feel of being an associate and a principal, and also perhaps what qualities you look for when you are recruiting an associate.
Hi, I'm Richard Jones. So I'm a full-time specialist practitioner and been a specialist practitioner for about 20 years now. Currently, I work as an associate for a group, Total Orthodontics, which is a group of practices which is now part of the Bupa network. Previously, I was a partner within that group, so I've got some experience of both owning and working as a director within a partner within a group of practices, and also now working as an associate as well within a corporate setting. And historically, I've worked as an associate in other non-corporate settings as well. Simon.
Hi. So I'm Simon Jackson. I'm an associate in a mixed private NHS practice, and I'm also a BSA assessor.
So Artie, going back to your question then about what's not to like and to like, you know, as an associate or a principal. Well, I think specialist practice is an enormously rewarding career. I certainly got no regrets about pursuing it, and I think I've enjoyed in different ways every facet of my sort of journey, really, both working as an associate before becoming a principal. I really enjoyed then becoming a principal. I think it's quite exciting. I find the business side of things quite exciting as well as the clinical side of things. So I enjoyed that journey, being part of a team that grew a business. And so very much enjoy that, but that, you know, that has a lot of stress associated with it as well. So I think one of the attractions of being an associate is not having perhaps that stress of running the business. And now I'm sort of working as an associate again, so I've sort of offloaded a lot of that stress of running the business as well. I think most people will find that as an associate, whether it's in a corporate setting or a non-corporate setting, you do enjoy, you know, quite a degree of clinical freedom. And I think the diversity of cases that you do see is quite, you know, is very, very varied, you know, so I don't think you have to work exclusively in a hospital setting to enjoy that sort of variation as well. And I think private practice is also becoming more and more exciting all the time with new product development to the digital side of things. And I think in a specialist practice setting, there is perhaps more opportunity to explore those avenues than there is perhaps in a hospital setting. So I think it's certainly a career I would recommend to anyone.
Thank you. And Simon, comments from yourself about perhaps what you'd look for if you were recruiting an associate?
someone who can be part of a team. It's really important that you get on with the whole of the team that you're working with, nurses, reception, and the other clinicians. I work in a multi-surgery practice, which I prefer. I have worked in single-handed practices before, but that ability to discuss cases with colleagues, because you never fail to come across cases which are unusual, that you've maybe not seen before, and that ability to just go through treatment planning with colleagues is invaluable, even at my age. So yeah, I would always favour personally a larger practice where at least you've got some clinical support.
Perfect. Thank you both. I'll hand it over to Orla now to talk about pay and other things in private practice.
Yes, so my questions are relative to kind of specialist practice and taking on patients in specialist practice. So just to start with, if you're starting in a practice and associate seeing private patients, how would one expect to be paid in terms of percentage split and when you would receive that payment, whether it would be all up front or divided over several months?
Well, I thought maybe if I kick off on this section, I mean, there is a lot of variation, I will stress. I mean, typically with most associate agreements, when it comes to private care, these are normally dealt with on a percentage basis. So you have a split or effectively a license fee that you pay to the practice, and then the associate will get a split of that. I think with private work, and splits with NHS work tend to be different, and perhaps we'll come on to that. But with private work, a 50-50 split is still quite common. It's not the rule, but it certainly is quite common. And you would typically then split lab and material costs on a fairly similar basis. I have had some experience of contracts where actually the associates get a lower split, but perhaps they don't pick up laboratory and material costs. So it sort of works out fairly similar. With the exception of things like Invisalign, lab and material costs typically work out at about 14%, 12 to 14% of gross. So you can probably expect your split to drop by about 7% once you factor in material costs and brackets and so on. So that's a fairly typical arrangement. In terms of how the associate is paid, this is varied. I know Simon's experience is slightly different to mine, so I'll explain how it works in the practices that I work in. And normally the associate is paid a fee on bond up. So if I start a case, for example, I get a proportion of the final fee at bond up, and that effectively covers the extra time put in at that point in the process, plus the material costs are obviously front loaded as well. And then the remaining is paid incrementally over a period of time. In our business, it's 18 months. So I'd get 50% of the costs at the start, and the remaining part is then fed to me over an 18-month period. The theory behind that is that it's sort of in line with the treatment. It also means that if, for example, I was to leave midway through treatment, it makes the transfer of that case to someone else relatively easy, and the payments would then just pass to the person then taking on that case. So that's the way it works with me. But I know Simon's got a slightly different arrangement. Perhaps he could explain how it works in his setting.
Yeah, in our practice, the payment's paid per month depending on what the patient has paid, what income has been received from patients. So if several private patients pay up front, that is added to your gross and you take a percentage of that. There hasn't been an issue with that because nobody's in the practice has left mid-treatment of a private patient. But if they were to do that, then a pro rata rate would be calculated and there'd be a degree of clawback of those fees owed to the practice.
And sorry, Simon, would that clawback be relative to the amount of time left the patient is thought to have on their journey, or?
Yeah, the stage of treatment, rather like Richard's, it would be calculated in a similar fashion.
Okay.
I think there's no right or wrong really, and I think both those arrangements, work perfectly well. I think the important thing is it's all parties understand that from the outset, and that ideally that's written into the contract. So there's some sort of arrangement. I've become involved in a few disputes between principals and associates historically on such issues, and it largely stems from a misunderstanding between all the parties, or it not being in writing. So if an associate leaves and it's not written down that the fees will be clawed back, it can become an issue. So, but both methods work perfectly well. It just needs to be agreed and written down, really.
Okay. And if you start in a practice and you're taking on existing private patients that are mid-treatment, how could one expect to be reimbursed for those, or as the treatment kind of moves forward?
I think with the arrangement that I have, it's relatively simple because, say this, in essence, if the patient I left, a year into treatment, there would still be 6 months of payments left, and the new person would just take on those payments. And it should, in most cases, the split should be fair. So it tends to work out quite well. There are, of course, some issues. Occasionally, maybe a very prolonged treatment, and actually those fees may have run out. And if there's no agreement in place for the principal to claw back some money from the associate who's leaving, then in effect there's no money to pay the next person, and that can, of course, create an issue. And it's not reasonable to expect that associate to do the work for nothing. So that can be an issue. But yeah, I mean, I certainly, as an associate, you wouldn't be expected, or I wouldn't expect to just take on that case and complete it for no fee whatsoever. But that is something that clearly needs to be discussed. But in theory, there should be a mechanism in place for the fees to pass to the new associate. And say Simon's example is the same. There would be clawback from the person who's left, and I guess that those fees would then be paid to the new associate.
And if you take on patients like that and you're getting that pro rata payment, when it comes to debond, which is another sort of an expense at the end, is there a way that that's added on, or do you still pay that 50% for the retainers? Say if you're getting lab made bond retainers and vacuum forms, there is a cost there.
Yeah, normally, yes, absolutely. So once you've taken on the patient, it becomes your patient, and you're then inheriting the fees. You would then obviously take on the split of the lab fees as well. So that would be the normal arrangement.
Okay, that's great, thank you. And then just moving on to aligners, some questions have come in about whether or not it would be best to use your own aligner account, or whether it would be appropriate to use another clinician's or even the practice account, and what are the kind of relative pros and cons of that?
Yeah, I mean, from personal experience, I've only ever worked in scenarios where we have separate accounts. Now, I can completely understand the attraction of having one account in terms of discounts. Now, I work in a corporate setting, and even before that, when we owned the business, we sort of negotiated with Align Technology to have effectively a group discount, so a sort of a standard discount across the group that everyone got. So we could, in effect, then all have our individual accounts, but we all benefited from the group volume, basically. I think the benefit of that is it's a lot easier to administer. I think you haven't got issues with patient confidentiality either, because you can, of course, access these records from anywhere, not just on the practice setting as well. So I think if you do have a group of clinicians using the same account, that could be potentially a little bit of an issue. So I've not worked in a setting where people share an account. I wouldn't be entirely comfortable with that myself, but I can see the attraction in terms of the discount that it might attract. So
I think that another additional point to add to what Richard has said, I completely agree with benefits of having separate accounts, because otherwise when you move on to another practice, or if you work in multiple practices, you're not building up your own case numbers and points with Align or whichever system that you're using. But also to point out that there are quite a few practices at the moment who do insist that an associate uses one account for the whole practice. So I think that it is an important point for an associate to consider if they are taking on that, that they won't be building up any cases of their own, and there is nothing to show then when they leave and move on in the future.
When I started down the path of the Invisalign, there was another associate who was quite a few months ahead of me, but I decided to use my own account to build up my own profile. So it meant that I wasn't receiving the same discount at the start, so my lab bills were much higher. But in the long term, I felt that was worthwhile.
And another point is you won't appear when a patient searches for you as a doctor in your area if you haven't got those case numbers. Even if you've done a lot of cases in the past and then you've moved on to another practice, there's no evidence of that. So a patient, you won't appear to a patient. They'll have a lot of general practitioners who will have done a lot more cases and other practitioners in the area, and they'll all be listed first.
Another thing to mention, perhaps, I know Invisalign obviously are the largest market player in this particular area, but there are now a lot of other companies that have got very respectable systems that are sort of hot on their tails, and they do seem to have a bit more flexibility when it comes to discounts as well. So a lot of these companies will, put you on quite a high discount straight away, but whereas Align tend to want you to build a profile from scratch, and it might take you some time to build up to a decent level of discount.
That's great, thank you. And just moving on to a kind of comparison between an independent practice and working for a more corporate-sided practice. You hear things like you'll have less clinical freedom, less choice of materials. And what would you say to people about that? And what do you feel are the key differences between working for an independent practice and working for a corporate?
Well, Simon, you're about to.
Well, I would say I work for an independent practice, but I don't have complete clinical freedom about the materials we use. The practice principle, there's some negotiation, but they will favour a certain material, and when you're certainly getting materials in bulk, you need to stick with one or two suppliers for it to be cost effective.
Yeah, I mean, I'd certainly agree, but in my experience, I don't think it's something you need to be too concerned about. So I've worked in lots of different practices, and also, being a partner in a number of practices as well. And we've operated much along the lines Simon suggested. We've had preferences for materials, but equally we've given associates choice. So, we don't just have one bracket system or one type of arch wire. There will be a selection, but what we don't want is to have 20 different bracket systems in the practice, because it makes the inventory very difficult for the staff. It means you're not getting the discounts that you might desire, and obviously those costs have to be passed on to the associates. So if you can settle on a few bracket systems that you all like, and good quality ones, you can negotiate good prices, so everyone benefits. Practice runs smoother, inventory becomes a lot easier, and it just runs an awful lot better, really. So we've never, when I was say one of the partners, we never really had associates who joined us who found that to be a big issue, even though we were maybe giving them a choice of 3 different metal brackets and a couple of different porcelain brackets. They felt they had plenty of choice, and we've since moved into a corporate setting, but actually that hasn't really changed. And so from my experience, most of the corporates actually, if anything, there's probably a little bit more clinical choice now, because the corporates have got quite good discounts with many different suppliers. So there's a little bit more clinical freedom, if anything. So I think you'll find actually with people going into a corporate setting, it's not something they need to be too fearful of.
Thank you. I think that finishes off my section on private practice and corporates.
So we're going to move on now to talking about associate pay for NHS work. So the first question, that's one of the most common ones, is what should an associate expect in terms of percentage split, in terms of the contract value, so the percentage split for the number of UAs they're taking, but also in terms of therapists as well, and the payments that they should be expecting to be making towards that.
Okay, so maybe I can start off. There is quite a bit of variation on this. Now, going back to when I started as an NHS associate, which is pre the PDS contract, 50-50 splits were fairly commonplace, and that really hasn't been the case for quite a number of years now. And I think the profit margin on NHS work for practice principals is certainly something that's dwindled with respect to NHS work for quite a few years. So that sort of split isn't typical anymore. I think 45% is at the upper end of splits nowadays. Certainly within our business, a normal figure is about 42.5% for NHS work. But there is a bit of variation around the country. There are some parts of the country certainly where recruitment can be more of an issue, and perhaps the costs associated with running the practice are slightly lower, and some of these practices may offer slightly more favourable terms when it comes to the split. On the other hand, some of those practices where running costs are very high and perhaps there's more potential for private work and more competition with a greater number of orthodontists, splits might be slightly lower. But you certainly very, very rarely will you hear of agreements going for 50% nowadays. The one thing I would mention, though, I mean, I've often been approached by people almost like trying to barter a little bit and saying, well, I've got a colleague who's getting 45%. But you have to ask yourself, 45% of what? And there are examples where the principal might change the UOA value. So they're not necessarily passing on the same UOA value to the associate. So they might be offering a higher percentage, but it might give a slightly lower UOA value. So that's something to just be mindful of as well. I think it's better just to, just keep an eye on, what the sort of the headline figure is that you're sort of taking home, I suppose, is something to focus on a little bit more. And again, there are different deals in terms of how the materials and the therapists are handled. So again, in our particular business, and many of the associates within the group have got slightly different structures. So there are some people who actually have quite low percentages, but they're supervising quite a number of therapists. And so they're getting a very large number of units. So in effect, they're not paying for the therapists, but they're getting a lower percentage. But overall, their take-home pay might be significantly better. So it's again worth just taking that into account. In terms of therapists, so some associates will get a lower percentage, but they get the use of a therapist, or they might supervise a therapist. Other people might contribute towards the hourly rate, and we've got both arrangements within our group. So there's not one particular arrangement. So typically they might pay a 50% split of the therapist's hourly rate, and both methods work quite well. What arrangements do you have in your practice, Simon?
It's 50-50 split, but that's historic. So I've been there a long time, as is the other associate. So lab bills are 50-50. We don't have access to the therapist. That's purely for the principal.
Okay. So yeah, I think you will find it. I think Simon's agreement, as I say, is historic and probably more favourable than most new associates would find nowadays, I think, with newer contracts.
So we've talked a bit about the possible contribution towards materials, lab bills and therapists. One thing that's come up more recently with the introduction of digital equipment is obviously the charge for scans as well. Is that something that is becoming increasingly common at the moment?
Now, I took a decision, even though I was an associate, I bought my own scanner. So I paid for my own scanner and I utilised that. The practice provide all the scanner sleeves and don't charge me for that. But with the scanners, every now and again, there are good deals where you're not paying for the cloud storage. So it just happened to, financially, it worked out for me, rather than paying the lab fees for study models and those having then to be scanned. It was easier just to, financially, it was better off by having my own scanner.
And within our group, there's been a gradual transition to scanning for most patients. So now I'm not aware of people being charged for those scans in any way. So we obviously used to pay a share of study models, then we moved to digital study models, but from impressions, there was a cost attached to that, and they were treated in much the same way as plaster models. But since we moved to pure scanning, if there's no extra cost, then the cost of the scan isn't passed on to the associates. I'm not, it obviously does happen, but I'm not aware personally of practices that operate in that way. I wouldn't think that's entirely a reasonable thing to do myself, but yeah, it obviously does happen.
That's great, thank you. So we talked about the percentage split, but there are obviously a number of different ways that practices can pay an associate, and one of the more common ones in terms of alternatives is an hourly or sessional rate. How does that work?
Yeah, so I mean, this is quite common. It's particularly common when it comes to locums, so for shorter term appointments. In our business, we operated in this way occasionally, particularly when you have a new associate, perhaps joining midway through a contract year, or perhaps someone who's coming in to do a specific role that doesn't quite fit the normal model. And the hourly rate can work quite well, particularly, you know, it allows associates and principals to sort of test each other out a little bit, really. So we always used to work on an hourly rate for a period of time and then move the associate onto a more typical percentage split, which is probably the more common way of doing it. I think hourly rates can be attractive, and I think there's certainly some very attractive hourly rates out there. I think from a practice perspective, one of the issues, and we've certainly experienced this when you employ people on an hourly rate, is there's no incentive to actually progress things. And we've certainly had, you know, examples where we've had people come to work for us, and actually you look 6 months later and actually no cases have been finished in that time, and there's been a lot of molasses have been changed. So I'm not suggesting that's people do deliberately do that, but I think having a percentage split and a target to hit just focuses the mind, and I think it makes people become a lot more effective. So I think if you are employing someone on an hourly rate, it's something for the principals to really just keep on and top of in terms of managing productivity, I suppose. I think ultimately, say the hourly rates nowadays, they can be very good, you know, particularly as there are some areas where, particularly with some of these newer contracts, there's still a shortage of orthodontists in some areas. So there are some attractive rates out there. I think long term, having a percentage based split is probably a better option, because I think it just allows you to take ownership of your cases. And I think as I say, it just focuses the mind a little bit. And I think the financial rewards are probably slightly better as well in the long term.
So just to clarify, for those who are looking into contracts with an hourly rate, it's not expected that there will be lab bills, material costs, therapist costs. That's all included.
Should be, yeah, absolutely. That's the way they normally work.
There isn't usually a target as well.
Well, yeah, there might be. Yeah, there might be, because ultimately the practice has a target, you know. So they will be, you know, looking to expect a certain level of productivity. Now, whether that target is something that they, you know, they share transparently with the associate, or whether, you know, as in, you know, our case, for example, that the diary is simply managed, you know, and as long as I turn up to work, I will hit my target, because the diary is carefully zoned to have the right number of starts in, you know. So if that is being done, then in theory, you know, when we used to employ people on an hourly rate, we in the background knew what the target was, and we would ensure that the diary was booked accordingly so that the target was hit, but we wouldn't necessarily make the associate aware of what that target was. But I'm not aware of sort of targets as such that you might get some sort of penalty for not hitting the target. But certainly there will be a target in mind.
That's great. So moving on to the topic of transfers, which is one that is often a question that new associates want to know about. What is a reasonable caseload in terms of the number of transfers to expect in relation to the number of UOAs that you're taking?
Well, I think to answer this question, you need to understand how the PDS contract works. A lot of people still mistakenly think of it as a fee per item, like a private sort of scale, really, and it's not really the case. So what you're basically being paid for is to provide a service. So as a practice, you have a contract for a certain number of UOAs, and that service includes starting cases in line with that number of UOAs, but also managing an active caseload which is consistent with that level of case starts. So in some ways it is a bit more analogous to, you know, a salaried service in a way. And so there will always be an active caseload, and in a stable practice with the same number of units, that caseload should stay, you know, fairly steady and consistent. Now, typically, and Simon will, I'm sure, confirm this, but I think the BSA data, I think, suggests the average caseload, a case duration is 21 months. And certainly when we were doing some work discussing close down contracts a couple of years ago, that was the figure that we used. So in theory, the average caseload, if the case duration is 21 months, the caseload is going to be 1 3/4 times the level of case starts. So if you start 100 cases a year, your caseload should be around about 175 at any one point. Now, that is an average, of course, and there will be variation either way from that, but that's probably a good figure, you know. So your caseload is probably 1.75 times your level of case starts, and if it deviates hugely either way, then you know there probably isn't something quite right. But as a new associate, if you were going into a practice with a target of UOAs and you're expected to take on a caseload consistent with that, that would be roughly the number you should be looking at. If it's significantly higher than that, and it might be, of course, if you're inheriting someone else's caseload, it might be that they haven't been particularly efficient and the number of cases has risen. But if it's way outside that figure, then that's something I think the associates need to be a little bit cautious of.
And in terms of new contracts that are coming out at the moment, certainly in the north there are new contracts that are being allocated whereby associates joining those practices may not have any transfers to take on. So what are the options for the way the associate is paid if there are no transfers at all?
Well, I think there's a number of ways this could be dealt with. So in theory, if the associate was paid the normal split, in effect, they're being paid probably a bit too much, because they're starting the cases, but they're not looking after the caseload consistent with that level. Now, it's useful to note how the practices are being paid. So with these new contracts, where they're starting with no cases in treatment, whilst they have a contract for a certain number of UOAs, they're not paid the full amount in the first 2 years. So in year one, the practice receives 85% of the contract value. In year two, I believe it's 96%. And then they move on to 100% from year three. So one approach would be to use the same model. So in effect, the associate payment varies in exactly the same way. And that's so it mirrors the arrangement that the practice has with the NHS, and I think that's a fair way of doing it. So that would be one option of doing it. Second would, of course, be to use an hourly rate for perhaps that interim period whilst the caseload is building up. Once you get to a point where the caseload is steady, then switch to a percentage-based contract, and that would also work, I think. I think personally, I'd probably, you know, if I was operating my own business in that way, I'd probably use the model that the NHS use, effectively treat the associate the way the NHS treats the practice, and I think that's a fair arrangement.
So just to give that as an example then, so if an associate is taking 2,000 UOAs and it was on a 50% basis, then it would be 50% of the UOA value times 2,000. So over a 12-month period, the usual way that that's paid is divided into 12 equal payments. But then in the first year, that would be 85% of that that's being paid.
Yes, that's right.
Great, thank you. So the next point is how many UOAs to start with. For example, if you're looking at working 1 day a week in a practice, what would be the suggested number?
Again, quite a lot of variation, and I think in recent times, with COVID, that sort of impacted on things again. So we're not in quite a normal situation. The figure we always used to work to when we were sort of planning these things was a reasonably productive associate could cope with about up to 1,500 units per day that they're doing. So that's around about 70 starts a year, something like that. But we had a lot of variation, and we had 1 or 2 very, very efficient associates who did a bit more than that. Some less experienced who would have figures of less than that. I think those numbers, have become increasingly difficult to achieve because there's a lot more red tape involved nowadays with cases. And I think, just expectations of patients have just increased a little bit when it comes to the sort of customer service side. So I think things probably aren't quite as, there's a bit more time pressure than they used to be. So, but I would say sort of between 1,300 and 1,500 isn't unreasonable for a clinician to service on their own. And obviously, if they're using a therapist, that might be slightly higher. What's the experience in your practice, Simon? So,
yeah, it's roughly along those lines, though COVID has impacted on that. And not only during the pandemic and the aftermath, I think that going forward will continue. Just that increasing amount of time that you're expected to spend between patients. And I would imagine somebody like CQC would expect certain standards to be maintained that were present during COVID.
And if there is working with a therapist as part of that, would you say to calculate that on a similar level? So, for example, you're doing 1 day every week and you've got 1 therapist with you. So would you be looking at approximately 1,500 times 2 to take on for the contract?
Not generally for a therapist.
No. Again, when we sort of calculate this ourselves, we sort of, a good therapist we found was capable of doing about 1,000 units per day. So a bit lower, because the appointments need to be that much longer. So the way we used to plan it, if I was working alongside a therapist, my target would be slightly lower because I have to factor in time to supervise the therapist. So we found generally an associate working alongside a therapist would probably do about 2,000, 2,200 between them for the day. If I was supervising 2 therapists, I would have even less in my diary. Once you get to a point where you're supervising 3 therapists, it's not particularly practical seeing your own patients at the same time. So there are examples of people who will just supervise 3 therapists, but they don't have their own diary and see their own patients. But it's probably about 1,000 units per therapist per day, I would say.
Okay. In terms of clawback when an associate leaves, obviously we've talked about a number of different models that can be used. What are the options for calculating that? So there's those on an hourly rate wouldn't be expecting that, but those who are on a percentage split, how would that work?
Well, it depends a little bit on the type of contract that you have. Now, most associate contracts say they're on a percentage split, and the arrangements effectively mirror the arrangements that the contractor has with the NHS. So, if I use that as an example, so if as a contractor my contract ended, as a lot of contracts did end with procurement, or I served notice on the contract, as soon as we stop taking payments, our obligation to treat the patients ends. And those cases would effectively follow the contract to the new provider, or a closed down contract will be put in place. Now, in theory, it's exactly the same with associates. If you've got a percentage-based contract which mirrors the PDS arrangement, when you finish your term with that particular practice, your obligation to finish those cases also then passes with the units to the person who takes on that contract. So the caseload just passes sideways. So if it's managed in that way, and most are, there shouldn't be any clawback as such. Just the caseload just passes with the contract to the next person. But it is worth checking that arrangement and make sure the contract reflects that, because we are seeing some other different models. And there are Code is another reputable company, and they've got a slightly different contract model that they use, and they treat the NHS payment a little bit like a fee per item payment. So they do it in a slightly different way. So in effect, with their model, there would be some clawback. But the vast majority of associate contracts I've come across follow a similar model to the BDA version, which in effect treats the associate the same way that the practice is treated. So there shouldn't be clawback as long as they are on top of their contract, you know.
And if it is an example that we spoke about earlier where there are no transfers to start, what about in that example? So if, for example, they are going with the suggestion of 85% for that first year, and then rising to 96% in the second year and 100 in the third year, if that associate were to leave in the second year, that should mean, with that percentage factored in, that they wouldn't be expecting any clawback?
No, it shouldn't be. So it's quite simply the cases would then pass to whoever comes in to take on that work, really. So.
And one of the things I was going to mention was types of contracts, but you touched on that there, which is the BDA and the Code, which I believe is the Confederation of Dental Employers. But just a point for associates that the BDA does offer a contract checking service, which is really useful. Even if it's not their model of the contract, it is worth running it past them if you've got that level of membership with them. So just a couple more questions. How is the superannuation calculated, and are there any resources that you'd refer associates to help them understand that a bit more?
Yeah, superannuation it's an area I think that is still quite misunderstood. Now, in terms of resources, first of all, there is quite a lot out there on how to calculate NPE, and perhaps we can share the links to that, because these documents are out there and they're very, very comprehensive in terms of how to do it. Now, it is an area that's quite often misunderstood. Now, in terms of superannuation, essentially as an associate, your superannuation essentially is based on your what's called net pensionable earnings, and this is something that is misunderstood. And some practices, when they make an annual declaration of the net pensionable earnings within the contract, within the practice, and a lot of people mistakenly put it down as 43.9% of the gross value of the contract. So in examples where associates are being paid on an hourly rate and perhaps don't have a target, you know, we do see examples where they're not given any net pensionable earnings at all. But that's not how it's done. Net pensionable earnings is quite simply what you are paid. So, and that is it. After deductions, it is what you are paid. The 43.9% simply refers to the ceiling, the total superannuation ceiling for the entire practice, which can't exceed 43.9% of the gross. But it is what you're paid. So if you're being paid an hourly rate, irrespective of what target or not you have, that is your net pensionable earnings, and that is what should be declared on the form, and that will then form the basis of things like maternity pay, sick pay, and so on, and pension contributions, of course. Similarly, if you're paid on a percentage basis, it should be your take-home pay after deductions that is your net pensionable earnings on the form. But the practice threshold can't go above 43.9%, and that's how it works. This is written very clearly in the official guidance, and there are worked examples of how to do this, including working it out for people who are paid on an hourly rate. So it's all there in the guidance, and we can perhaps share those resources.
And where can someone find those, Richard?
Well, they are, I can't remember off the top of my head, I can't remember. They are very easily available online. So if you simply Google net pensionable earnings in dentistry, you will find the guidance, but I'm sure we can share those links, and I can easily access those. And
in terms of showing as a performer on Compass, that should be, even if you're on an hourly rate, there should still be use of Compass for that associate, shouldn't there?
Yeah, I think so. I believe so.
Yeah. In terms of being self-employed and employed, obviously we expect that all the different models that we've described are being self-employed. Are there any more different, more unusual ways that it could be deemed as being employed, that associates need to look out for that to make sure that they know the difference if they are signing up for something a bit different?
Well, I think this is something that's under sort of new scrutiny at the moment, and for many years there's almost been an agreement, an unwritten agreement with HMRC that associate contracts in dentistry have been treated as self-employed. That's no longer the case. Now, that's not to say that they're not being treated as self-employed, but in effect, what HMRC have said is that each contract will be, judged individually. So they are up for scrutiny, and there is a test that you can apply, and it determines whether you are self-employed or employed. And there's certain things that you need to be able to demonstrate to satisfy HMRC that you are self-employed. So among those things are the ability to, so there are some things, I'll go back actually, there are some things that start to push you more towards being employed. So if your take-home pay doesn't vary, that's something that will start pushing you towards employed. If you have dictated annual leave or dictated hours, that will again push you more towards being employed. If you are unable to make a loss, again, that starts to push you towards being employed. So these are things that in your contract, if you have an hourly rate or you have a fixed sessional fee, that is starting to push you more down the employed route. Whereas on the other hand, if you have a percentage-based contract and one that varies month to month with lab fees and material costs, that's pushing you more down the self-employed route. Similarly, the ability to employ a locum helps to push you more down the self-employed route as well, and the ability to make a loss. So, for example, if you have to refund patients or there's clawback, that sort of thing, again, it all helps justify self-employed status. So there are lots of things to look out for. Again, probably another good reason to get contracts checked. I would also recommend, as well as the BDA service you've mentioned, Nadia, let's not forget as well, the BOS does have some legal support as well. And there is a legal helpline which is available to all members to look at a variety of things. It was originally set up to help with procurement and tendering, but the BOS legal team will help look at a variety of things, and all members are entitled to a certain amount of free time, and that's with Julie Norris.
That's a really useful reminder. If someone is on an hourly rate or a sessional rate, the only way to vary each month would be in what way would it vary? It could be private earnings or.
Yeah. I mean, again, maybe private earnings are treated differently. Obviously, the hours might vary slightly each month, but it does become increasingly difficult to justify self-employed status.
And the last question on this section is the difference between GDS and PDS for orthodontic contracts. Simon, is that one that you'd be able to take?
I think Richard's more informed on that, the difference between the PDS and GDS.
Yeah, sure. I mean, there are still a number of GDS contracts out there that do orthodontics. Now, the vast majority of specialist practices have a PDS contract. However, historically, and there still are a number of dental practices who provided some orthodontic services alongside general dental services back before 2006. And many of those practices have a GDS contract, which might cover general dentistry plus orthodontics. I suppose the key difference is PDS contracts are time limited, and so they are fixed term contracts. Almost all PDS contracts, there are one or two exceptions, but almost all PDS contracts in the country have been renewed several times since 2006, and most have now gone through a procurement process as well. So in terms of differences, first of all, they're time limited. Secondly, the UOA values will have, there's been a bit of pressure on the UOA values with PDS contracts. So most PDS contracts have seen those UOA values drop with the new procurement. So it started off at £55 back in 2006. Through incremental increases, probably got up to mid-60s. And for many practices now, it's back down in the high 50s. However, GDS contracts are not time limited. So they've carried on from 2006 with the annual increments going on. So a lot of GDS contracts you'll find have actually got significantly higher UOA values than the PDS contracts, and they don't have a time limit on them. But in terms of the way the contract is managed, it's exactly the same. So it's the same number of units per case. They're treated in exactly the same way, and they're monitored in the same way as well.
Richard, I've got a question. Is a principal obliged to tell you their true UOA value?
I don't know, to be honest with you. You see this quite commonly, probably more in dentistry than in orthodontics, where the principals change the UOA. Well, in fact, you get different UDA values within practices. You know, different associates might have different UDA values. Orthodontics was unusual. So when we went back to 2006, we leveled the playing field. We made the UOA value the same for everyone in the country at that point. Whereas in dentistry, that wasn't. Everyone had different UDA values. So you had different UDA values within the same practice. So it became really complicated. But a lot of principals might top slice a little bit of the UDA and then, you know, effectively agree an internal UDA to pay an associate. You don't see that as commonly in orthodontics, but certainly some practices will alter the UOA value slightly. It's not difficult to work out. You can, you know, there is, you know, you can effectively obtain the information in terms of what the total number of units is for a practice and what the contract value is. So it's not too difficult to actually work it out.
Thank you. That wraps up that section. That was really useful.
So my questions pertain to your expectations towards the NHS BSA as an associate in primary care. So first, a lot of questions is surrounding UOAs and UOA values. So just very quickly, could you tell me how many UOAs are allocated to an orthodontic case?
Usually it's 21 UOAs for a treatment, unless the patient is under 10, and then it will attract 4 UOAs. Now, most contracts don't have any facility to treat patients over 18, but because of the pandemic, 18-year-olds are being accepted for treatment, so long as you fill in the correct form online for the BSA. And they attract, I believe, if I'm right, Richard, 23 units?
23, that's right, yeah. Mm-hmm.
And what form is that for the NHS BSA? Is an associate expected to complete that form to apply for an 18-year-old to have treatment?
It's a box you tick on the online form. All software providers should have that facility, and most forms now are available on most software packages. And it's just a simple tick box.
Perfect. And is that something that in your experience, is that something that the associate puts through online, or does the associate just do the paper version and then someone else within the practice puts that through online?
Generally, you'll write out the treatment plan, you'll fill in part of the FP17 DCO, and then your nurse should cross-check that. And if it's a paper form, or a treatment coordinator will get that form signed. It's worth, as an associate, also making sure that if you're using paper forms, that they are copied to the notes before you start the treatment, because it's a statutory requirement under the GDS regulation, under the regulations, that you obtain a copy and keep it on the notes, except for the case where some practices will use their own practice-based consent forms. Now, if that consent form contains all the data that you would normally get on an FP17 DCO, and it's specific for the patient you're treating, that is acceptable, an acceptable alternative.
I think going back to your question about who processes it, Artie, I think you'll find that does vary practice to practice. I mean, speaking from personal experience, the manager of the practice tends to take the lead role in that. So I don't process the claims myself. So they very much keep on top of that, and they'll actually handle the processing of the claims, and so they're very on board with it. But I am aware of practices where they do ask the associates to do that themselves, and each associate is responsible for submitting their own claims and effectively managing their own target. So again, in the practices I work in, so for example, if an associate had a particular target for the year, in essence, my diary is planned for me. So as long as I turn up for work and do what's sort of put in front of me, I will hit that target because it's sort of managed carefully. Whereas, again, some practices rely on the associates to very much keep track of where they are with their UOAs to hit their target for the year. So I think you'll find that does vary practice to practice.
Thank you. With regards to just touching on that point about consent forms, Simon, would you say generally it's probably good practice to have your own orthodontic consent form alongside an FP17? Because
Yes.
I know FP17 is quite brief and there's not a lot of room to write all the risks and benefits of treatment or alternative treatments, etc.
Yeah, there should be their own practice consent form. But obviously that doesn't need to detail as much if you're doing the FP17 as well. But I think it's good practice that you've got the treatment plan on there and the proposed length of treatment, so it's a valid consent.
Some areas as well nowadays, it's not all areas of the country, but certainly some areas, the local NHS team also have an agreement that they want to get signed as well. And we certainly have one in the southeast. So it's called an orthodontist patient agreement. And essentially it outlines the commitment that the practice expects from the patient and what the patient can expect from the orthodontist. It's very much written by the NHS, so I'll be honest and say it's not particularly friendly as a form. But one of the requirements on that form is it specifies that the patient has been shown the BOS leaflet on the risks of orthodontic treatment, and the BOS have got quite a good leaflet on that. So if you do want one to provide patients with the risks, that's a good starting point. So with our NHS patients, in effect, there's 3 forms that we have to get signed. You've got the FP17 DCO. You've also got there's actually the blue form that parents have to sign to do with the claim. Then you've got the in-house consent form, which outlines the risks, benefits, and so on, plus this NHS agreement as well. So there's quite a bit of paperwork to get signed in advance.
It's worth checking as an associate that material is scanned onto the notes and recorded in the notes.
That blue form, are you talking about the PR form that's done by the parents that you mentioned?
Yes, Simon might know. It's the PR form, isn't it?
Yeah. And as an associate, do we need to check that that's also being scanned into the patient notes as well?
Don't know about that. You don't have to present that form.
Okay.
And with COVID, you get some circumstances where the clinician themselves can sign the form on behalf of the patient and the parent.
Perfect. Just another question surrounding UOA, Simon. You mentioned about interceptive treatment and being able to claim 4 UOAs for that. If you had a child who was you corrected an anterior crossbite for as an interceptive treatment, and they came back to you when they were 12, say, and they had a bit of crowding, could you treat them again if they met the IOTN criteria?
If they meet the IOTN criteria, under the current regulations, yes, you can treat them again.
Fine. And is there a specific appliance that you need to use for interceptive treatment? Do you need to use a removable appliance, or can you use any appliance that you feel is clinically appropriate for interceptive treatment?
You would use the most clinically appropriate appliance.
Okay. With regarding seeing patients, perhaps they might be a little bit too early. I understand you can claim 1 year away for that assessment. Let's say you review them again, you choose to review them again in 6 to 9 months, and they are still not quite ready for treatment. They're still in the mixed dentition. Could you claim another 1 year away again for that patient?
Theoretically, yes. And to actually be recording activity from a BSA's point of view, theoretically, you're supposed to make a claim every time. But if you did, that would cause a red flag with your ratios, which is one of the KPIs. So most practices would only make an assessment if they are discharging the patient because they're not eligible for treatment, or assess and review where they're going to qualify for treatment, but they're not likely to start for a considerable amount of time, and you've done a full assessment.
Yeah, that used to be a big issue, I think, in the early days of the PDS contract, because a lot of people were claiming every single time, and there was also a tendency for patients to be referred far too early. And as Simon said, what tends to happen then is your assessment to start ratio starts to escalate, and that causes a red flag. So nowadays contract management is a lot tighter. We've got these vital signs reports that are produced regularly, and within some of the newer PDS contracts, it's specifically in the contract as a KPI that your assessment to start ratio can't exceed a certain threshold. There are even some people whose contractors, as part of their bids, they actually put in the bids themselves that they would not claim for these reviews at all. So they're effectively doing them free of charge. So there is a slight technicality, because as Simon's highlighted, strictly speaking, when you're carrying out an NHS procedure, whether it's an exam or a treatment, you should be submitting a claim to make it an official NHS procedure. But a lot of people just don't, so they keep their ratios in check.
There's another grey area here as well. With COVID, a lot of people are doing virtual assessments. Now, there's no facility with the BSA for you to claim for that assessment at the moment. There is discussions about that, but at the moment, there's no real facility for you to claim that virtual assessment, no matter how thorough it is, as a unit of activity.
That's interesting. Just moving on to some of the other questions that I have here. One of them's around, I know that the NHS BSA, I don't know how often, but every few years they come around and they ask for, I think, 5 sets of records to inspect. Could you just elaborate a bit more about what that's about and why it's done, and what you're expected to send in?
It's clinical monitoring of standards. It's every 3 years, roughly, unless you've had a report which hasn't been a green report, and then it may be more often. And if you get a red report, they'll ask for another 5 cases straight away if they've got concerns. Generally what happens is they'll choose 5 consecutive finished claims that have been made on a contract, and they'll ask for the records of those consecutive claims. They are then assessed by clinical assessors based upon 3 categories: standard of clinical records, the treatment need, which is essentially the IOTN, and the standard of treatment. Each of those categories will be scored green, amber, red. Green means everything's satisfactory. Amber means it's actually satisfactory. There's just a few things which are not ideal. And then red, it's unsatisfactory and needs further investigation. Now, with the clinical records, it's the provider's responsibility to obtain accurate pre- and post-treatment records, but it's the performer's responsibility to check and verify those before they submit them. I think as assessors, you are constantly amazed that there is missing records, or a particular issue is models are forwarded which are incorrectly articulated, which makes assessment very difficult. Now, it's not a statutory requirement to send in photographs, but it is considered best practice. So if you don't submit pre and post-treatment photographs, you're likely to get an amber for your clinical records. Radiographs are normally required, and if you take a lateral KEF, you have to put an analysis on the OCA form. They'll expect an FP17 DCO or the practice-based equivalent, and they expect the OCA form to be filled in. What a lot of performers don't do is put their name on the simple things, like put the name on the OCA form or make any comments on if they're dissatisfied with the treatment. Doesn't mean to say they don't feel they've done a good job, but if you've got a patient that's been particularly challenging or a particularly challenging case. Another thing is also length of treatment. The standard length of treatment is about 21 months. If it's gone way beyond that because the patient moved away and then came back, let the assessors know. Now, the treatment need is the IOTN. The assessors will look at whether the IOTN scores are correct, and a number of people tend to kind of shy away from putting a 3D down. But if it's a 3D7, 3D8, justifiable, then put it down as that. Don't try and push it to a 4D. It's perfectly acceptable to treat 3D6 and above. With regards to the standard of treatment, for each case, the assessor will score that particular case based upon have they achieved the aims and objectives. If you haven't achieved your aims and objectives, you should really be submitting a case as discontinued. People don't like doing that because they're worried about it affecting their metrics, but it's better than that than having, say, a red or amber report. So over the 5 cases, you will look at the standard of the treatment, and it's kind of like a cumulative trove. Each one will get a red, amber, or green, each case. So if you've got 3 greens and 2 ambers, but they're pretty much satisfactory, you'll get an overall a green report. Vice versa, if you get 3 ambers and 2 greens, you're going to get an amber report. If you get a red report, they will ask for another 5 cases. And it's important to also put on the OCA form who's actually treated the patient, especially if there's been multiple providers. And especially if you've got transfer cases.
That was going to be one of my questions, so thank you for preempting that. You mentioned about talking about sending claims through as completed, discontinued, abandoned. How does an associate go about doing that if they're in a paper-based practice, for example? How would they go about that?
Well, there is the facility to do that on the forms. There's a box you tick which it's important to distinguish between treatment abandoned and treatment discontinued. Because the treatment discontinued is clinician-led, whereas the patient abandoned.
Sure, that makes sense.
Artie, just another point to mention around giving enough time for the models to be scanned, because they do require them in a certain digital format, and that can take quite some time to organise, especially if it's a practice that you've left and your cases have been identified as the ones that they want to assess. Then the practice and the associate who's no longer there need to allow enough time for all of the models to be transferred and digitally uploaded, and enable the associate to have access to the records that they need in order to complete the form, so that they can be involved in completing the form as they were one of the ones who treated the patient, or the only person who treated the patient as well.
I think most practices, you'll probably find the practice manager will organise collecting all the records together. If that does happen, I can't stress enough that as the performer, check the records before they go off, that they're correct and there's nothing missing, because it's only going to reflect on you, not the manager.
if a case has been transferred, so say if I had taken on a case and I'd written on my forms that this case was started by Dr. X, and I'm the person who's finished that case, for example, would my predecessor also need to have access to the forms before they get sent off to and the records before they get sent off to NHS BSA?
No.
Okay, perfect. I think that you've answered all of my questions surrounding UOAs and NHS BSA forms. Is there anything else that you think might be pertinent for associates to know, Simon, that we haven't already discussed about this area?
No, it's just making sure you've got good clinical records. And if you do get a transfer case, it's sometimes quite onerous trying to obtain the start records. So as a bare minimum, it's worth taking some photographs on that initial start and doing a scan if you can. But certainly photographs are underused.
Perfect, thank you so much.
One point to make on transfer cases, actually, because it is a slightly contentious area, but strictly speaking, an NHS patient can transfer into a new practice. And the person taking on the case is perfectly entitled to submit a claim for 21 units to effectively it counts as a case start, even though they've started the treatment somewhere else. A lot of NHS contract managers still don't quite understand this concept, and they feel that somehow they're paying twice for the patient's treatment. And there are certainly some parts of the country where there's a lot of pressure on providers to take transfer cases and not submit a claim at all. There's generally been a lot of resistance to that. So you are, in virtually every area I'm aware of, you are still entitled to submit a claim, and that will count towards your case starts.
Perfect, thank you.
I'd say quite often taking on transfer cases is more challenging than starting a case from scratch yourself.
Very much.
So I've got a few general practice management topics to cover and questions that have come in. So the first question is, how are patients triaged in practice?
So in terms of the NHS, in most parts of the country, not all necessarily, but most parts of the country, there's some sort of referral management system in place. And speaking from our experience, the way it works is that they come in through a system called REGO. There is an obligation on the practice to triage this information and to within a certain number of days. So typically one person within the practice or a number of clinicians within the practice would look at the referrals coming in and see if any extra information needs to be obtained, such as radiographs, some additional clinical information, and effectively determines how urgent it is to see that patient or not. We are, particularly over COVID, seeing a lot of the initial screening being done by video. As Simon's highlighted already, that there is a slight issue there in that you can't make a claim for that essentially as an official NHS appointment, but nevertheless it's quite an effective way of seeing these patients and screening them. But in theory, yeah, you should have some system in place so that the referrals are looked at, triaged in terms of urgency. Any extra information is obtained where necessary. How do you do it in your practice, Simon?
We have a slightly different system because we don't have a referral management system in our area. So historically, we just had paper referrals. With the advent of COVID, we now have a system where patients or GDPs submit photographs of the patient. And we find that is a much more efficient way of doing it because there's no denying the oral hygiene levels. There's no denying whether they're in the permanent dentition or not, and you get a lot more information than you would just a paper referral. We share those out equally amongst everybody, and then we triage them in terms of how urgent they need to be seen, and they go into different categories. Are they ready for treatment? Do we need further information, such as radiographs, or just further clinical information from the referring practitioner?
So I just wanted to ask about PAR scoring. When is it due, and how do we go about submitting it?
Generally, at contract level, you're expected to do 20 cases plus 10% of your contract, submit PAR scores for those. Though the BSA get the data, and they generally, it's 90% of the contract cases are PAR scored. Now, generally, the way we do it in our practice is when we start a case, as the nurse, after bonding up the case, as the nurse is actually going through the instructions for the patient, I will PAR score the models on the digital form online, the BSA form. So therefore, we'll have the start PAR. At the end of the case at debond, we then PAR score the case again. If you haven't been calibrated, a mistake a lot of people make is they sometimes claim a 100% improvement in PAR. No, it's impossible to get 100%. The best you can get on the AP relationship, the molar relationship, is a 1 each side. According to the calibration course, 0 doesn't exist.
So do you have in your practice as routine that all the cases essentially get PAR scored at the beginning and end?
Yeah, every case. And when you submit your claim, the software we have will automatically generate that PAR score onto the claim. So the BSA get that data when they get the finished form.
And is that responsibility at practice level as opposed to an associate doing that?
Yeah, I'd say it's a good habit to get into, because it makes you actually look at your finishes, and there's no harm in doing that, and look at your starts and see how the case has developed. And I think it's a good learning experience more than the actual PAR score itself.
Sure. Thank you.
I'm just going to ask about how would it work for associates if they went off on sick leave, annual leave, maternity?
Well, again, I think it varies. I mean, again, one of the as a self-employed associate, you are usually within your contract permits you to employ a locum, and that tends to be the usual arrangement. You know, if someone's on maternity leave or paternity leave for a prolonged period of time, they would usually put in place a locum. Some practices will leave that very much to the associates to sort out. Other practices will take a little bit of a lead and help to source a locum for them. In terms of the arrangements, again, it does vary, but typically the associate, for example, going on maternity leave would get maternity pay based on, which is heavily influenced by their net pensionable earnings. So again, that's one of the reasons it's important to be able to demonstrate that. So you get your maternity pay, and that's sort of set at a level so that you should then be able to pay the locum effectively. So in that arrangement, normally the associate continues to be paid effectively as though they're still there, and is responsible for the locum costs. But other practices do it slightly differently, and we certainly used to do it slightly differently. In effect, the associate would get the maternity pay, but we would then take on the responsibility for the locum and effectively take the contract back for that period of time. So the associate got the maternity pay, and we would then pay the locum. Both arrangements work in a very similar way, and from a financial perspective, I think the associate is, it works out pretty much the same either way. But that's the usual way it would tend to be done.
Thank you. And just going on to referral, what would you consider as appropriate to refer to hospital, and what would you treat in practice?
Depends on the associate's clinical experience and the support they have within the practice. I wouldn't recommend anybody takes on a case that they feel is beyond their capabilities. Obviously, it's worth, when you start in a practice, finding out what the arrangements are with the local hospital and what sort of system they have and what issues they have in terms of waiting lists and what clinical support they're happy to give to you in terms of treatment planning advice.
The other thing to throw into the mix, I mean, orthodontics is one of the first specialties to have a proper care pathway for patients. And it's actually written, it's included within the documentation for the PDS contract now in terms of, you know, what cases are typically in the hospital, what cases should be treated in specialist practice. So it is in black and white a little bit more than perhaps it used to be. But Simon's absolutely right. A lot of hospital units vary. You know, there are some hospital units who perhaps take on a lot of teaching cases, so they actually want some of the more routine cases being referred to them. Other hospitals that have set the you know, their own IOTN threshold at a very high level. So there is a lot of variation. But in theory, you know, there are a lot of cases that we should be treating in specialist practice. You know, the simple hypodontia cases, you know, some impacted cases as well. It's certainly not the case that all of these cases should be referred to hospital. But yeah, the degree of clinical experience obviously factors in as well.
I think the MCN is also a useful place to have some discussion between primary and secondary care in an area, especially if you're not familiar with that area, to get an idea of what is referred there and any challenges that the secondary care are facing in terms of accepting referrals as well.
There are some regional variations as well where it's less common, but you will find some practices which have kind of bolt-on contracts to treat some of the more difficult cases, such as canines, large overjets, hypodontia. So those do exist, and you may come across that when you start working in a practice.
Is it a requirement as an NHS associate to be part of your MCN?
Yes.
And if you are a private orthodontic associate in that area only, should you also be invited to that MCN, or is that an NHS thing only, the MCN?
I think it's a worthwhile thing to join your MCN, just for the network, and the meetings will discuss a variety of factors, not just NHS.
Thank you.
At this stage, I think we're getting to the end of a lot of questions and ground covered. And I just wondered whether there are any other things that the panel would feel would be particularly useful for associates to know that we may not have covered.
I think asking a bit about the practice software is always useful, particularly if there is something like OrthoTrack or any of the other commonly used software programs that have a facility for orthodontics to be within that, because it makes the world of difference in terms of efficiency when seeing patients if various tabs are set up, letter templates, and also in terms of generating reports or pass scores, that kind of thing.
Probably find in most practices the nurse will know the software at the back of the hand, and it's a question of getting them to train you and show you around the software, certainly for the first few weeks.
Excellent. So it remains for me to say thank you to everyone who has helped put a lot of time forward to answer some of these frequently asked questions we have as newly graduated specialists. I've certainly found it useful, and I hope that it will be useful to our junior colleagues too. So thank you to Richard and Simon. And I'd also like to thank my fellow colleagues, Arti, Ola, and Nadia, for their time and hard work in reviving the mentoring program. If you are interested in signing up to the mentoring program, either as a mentee or mentor, please email secretary osg@bos.org.uk.